oral presentation at the IRI National Conference held recently. Thank you, Sonal, for accepting the invite and doing this for us on this platform. I'm sure the audience is going to be enthralled by our knowledge in musculoskeletal radiology, and it's going to be a didactic session. So the participants are requested to answer in the chat box and answer quickly so that we have more cases and more time to see more cases. Thanks, Sonal. All over to you for the next hour. Down for any technical help. Rest is up to you.
Thank you, Dr. Chinmay, for the kind introduction. So I will just quickly share my screen. So, this I collected some interesting cases, and it will be an interactive session. So you will have a timer on every case, and you can answer within that time frame. You can answer in your chat box, and it will be a good way. So starting with our first case. With shortening of the lower limb. Okay. Yeah, we are having some answers here. Right. So most of the answers are correct. Just a second. Just give me a second. I'm So as you can see, there is shortening of the right femur, and you can see hypoplasia of the head and neck region and proximal shaft. Okay. So the diagnosis is proximal focal femoral deficiency, or PFFD. And when we talk about congenital lower limb shortening, it can be because of proximal focal femoral deficiency, or maybe because of fibular hemimelia. And in 80% of cases, PFFD is associated with fibular hemimelia. And when we talk about the classification of PFFD, we have this Aitken classification. Here we classify the PFFD on the basis of degree of hypoplasia, the proximal femur. And what happens is that cartilaginous part of the femur is present, but it is hypoplastic, and there may or may not be a connection with the ossified part of the femur. And when we talk about fibular hemimelia, we have another classification, again based on the degree of hypoplasia of the fibula. So in fibular hemimelia, you can extend hypoplasia of the fibula, and it is often associated with aplasia or absence of the fifth digit. So that the case was PFFD with fibular hemimelia, and it was Aitken class C. So we'll move on to our next case. A 45-year-old male with back stiffness and pain in multiple large joints. What is the diagnosis? And can you see any radiographic sign here? And what is that sign? Okay, right. So we are getting some answers here. So the answer is ankylosing spondylitis, and we can see a dagger sign. So what happens here? As you can see, this is a photo of the dagger, and here we can see there is ossification of the interspinous and supraspinous ligament. which can lead to an appearance like dagger. So this is ankylosing spondylitis with dagger sign. This is another case of ankylosing spondylitis where we can see multiple syndesmophytes which are bridging across the vertebral bodies and the spine is almost fused. And in this radiograph, we can see fusion of bilateral sacroiliac joint, which often occurs in late stages of AS where we see bony ankylosis. Here is another case. It is not a case of AS, but I have kept this case to help you differentiate between osteophytes and syndesmophytes. So as you can see, this is a case of, you can see multiple large osteophytes here. So this is a radiograph of an old patient, and this patient presented with spondylodegenerative disease. And you can see multiple large osteophytes here. Here we can see claw osteophyte, which is bridging across the vertebral bodies and forming a false joint here. So you can see the clear difference between a syndesmophyte and an osteophyte. So osteophytes are basically thick and chunky, whereas syndesmophytes are very fine, linear, and thin. So this is osteophyte and that is syndesmophyte. And, and this is a radiograph of a case of flowing ossification along the anterior aspect of vertebral bodies in a case of a dish. So that is diffuse idiopathic skeletal hyperostosis. This is a case of advanced stage of AS where we can see fusion of the entire spine, giving bombus spine appearance. And again, we can see a dagger sign and, bilateral protrusio acetabuli and fusion of the sacroiliac joint. And these spines are basically very prone to injury and they can fracture easily. And the pattern of fracture is known as characteristic fracture. There's another radiograph of another patient with advanced AS where we can see fusion of bilateral hip joints. So large joints are also affected in AS quite frequently. And in bilateral sacroiliac joint also we can see fusion and bony ankylosis. So that is AS. Next case. So 25-year-old female with constitutional symptoms and backache. So what do you think it can be? Right. We have some answers here. So people are answering Pott's spine with abscess. Right. So basically, this is a these are radiographs of a 25-year-old female with constitutional symptoms and backache. Diagnosis is Pott's spine. Here we can see paraspinal widening of paraspinal spaces giving bird nest appearance. And here we can see contiguous involvement of two vertebral bodies with loss of disc space here. So this is a case of Pott's spine with paravertebral abscess, and this is a classic bird nest appearance. Next investigation will be MRI to look for spinal cord. Next, moving on to another case, we have another case of Pott's spine here. Again, contiguous involvement of two vertebral bodies with loss of disc space and plate involvement and vertebral body destruction over here. So this is another case. This is a case of late stage of Pott's spine where we can get bony ankylosis here, right? So next case, you can answer in the chat box. Okay, so What we can see here, bilateral hand radiographs and a radiograph of lumbosacral spine. So we can see an osteolytic lesion in this fifth metacarpal and another osteolytic lesion in the proximal phalange of second finger. And we can also see a large calculus or a radio opaque shadow in the renal area. So, and this is an ultrasound of the same patient in the thyroid region where we can see a well-defined hypoechoic nodule over here in the region of parathyroid. So this is a case of parathyroid adenoma with primary hyperparathyroidism. And these are basically brown tumors. And this is renal stones, which is quite frequent in cases of hyperparathyroidism. So when we talk about hyperparathyroidism, we have three types: primary, secondary, and tertiary. Primary is because of hyperproduction of parathyroid hormone from the gland itself. It may be because of hyperplasia or adenoma. And but the most frequent cause is adenoma, that is single in 85% of cases. Secondary is because of poor functioning kidney or CKD, where it leads to hyperproduction of hyperparathyroidism, parathyroid hormone, and leads to secondary hyperparathyroidism. So, radiologically, we can differentiate primary and secondary hyperparathyroidism on the basis of certain criteria, like brown tumor is more common in primary hyperparathyroidism. Osteopenia is more seen in primary cases, whereas secondary hyperparathyroidism cases, they have more extraosseous calcification, osteosclerosis, and rugged jersey spine. Next case. So this is a 15-year-old male with slowly progressive pain in right hip with limping. Okay. So this is a radiograph of a child, and you can see there is some problem in the right hip. There is involvement of the head as well as the acetabulum. There is slight widening of the joint space, maybe because of effusion. So the diagnosis in this case is infective arthritis, which is likely because of tubercular. And the triad, Femister triad, includes three things, that is periarticular osteoporosis, peripherally located bony erosions, and gradual diminution of the joint space. So all these factors, they suggest infective arthritis because of TB. So when we talk about TB hip, we have certain signs like wandering acetabulum, where acetabulum gets widened, and the head of femur it dislocates, subluxates superior-laterally, and mortar and pestle appearance, in which there is destruction of the head of femur and widening of acetabulum, which gives this appearance, mortar and pestle appearance. Then we have protrusio acetabuli, in which head of femur it shifts centrally, and sometimes we have this complete dislocation of the femoral head as well. Next case. So it's a case of 1-year-old child. What is the diagnosis and what are the risk factors? Okay, we have some answers here. So the answer is basically this child is having developmental dysplasia of hip bilaterally, more severe on right side. On right side, we can see complete dislocation of the head of femur outside the acetabulum. So this is a case of bilateral DDH. We're going to talk about some lines and angles over here, which are important when we evaluate a radiograph of DDH. So we have this Hill-Gendruner line, which goes through the triradiate cartilage, connects to triradiate cartilage. So horizontal line. And we have a Perkin line which transects the lateral edge of the acetabulum and it's perpendicular to the first line. Then we have a Shenton line which goes all along the medial part of the neck of femur and in the inferior margin of the superior pubic ramus. And then we have this angle, acetabular angle, which is normally less than 28° at birth and it progressively decreases with age. So with DD, normally head of femur, it lies in the inferior medial quadrant of this uh, crossing of the lines. And in cases of developmental dysplasia of hip, you won't see normal femoral head lying over here and it will dislocate laterally. And there will be breaking of this Shenton line and widening of the acetabular angle. So in this case, you can see the head of femur is not lying over the normal location and there is breaking of the Shenton line over here and widening of the acetabular angle. When we talk about risk factors, female gender, firstborn baby, family history, breech presentation, oligohydramnios, and spina bifida, all these are known risk factors for DDH. So basically, if there is less amniotic fluid in the uterus during pregnancy, it will lead to crumping of, and there will be less space to move the limb, and it can lead to TDH. Next case, 8-year-old child with right hip pain and limp. What is the diagnosis? What is the stage? And what are the classifications? Okay, so we have some answers over here. So in this pediatric patient, we can see AP and frog leg lateral view of the hip. And we can see left hip is quite normal, but on right side, there is flattening of the epiphysis and broadening of the neck of femur. So this is leg cuff Perthes disease. And in what happens in leg cuff Perthes disease, it is basically avascular necrosis of the femoral epiphysis. And it can lead to reactive joint effusion, which can lead to distension of the capsule and widening of the medial joint space. It can lead to crescent sign over here on radiograph, and it can also affect metaphysis. There can be widening of epiphysis, and there can be some osteolysis over the medial aspect of metaphysis over here, and widening of the neck of femur. So Leckow-Perthes disease basically affects predominantly 4 to 8 years of age. Boys are more commonly affected than girls. It is bilateral in 20% cases and 80% will develop osteoarthritis in long run. When we talk about classification, we have this Catterall classification, which is based on the extent of involvement of the epiphysis. And then we have a Herring classification or lateral pillar classification, in which we divide the epiphysis in 3 pillars. And basically, the lateral pillar is the most important one. And this classification divides the Perthes disease in 3 categories based on the involvement of lateral pillar. So in group A, there will be no lateral pillar involvement. In group B, there will be less than 50% involvement of the lateral pillar height. And in group C, there will be involvement of more than 50% of the lateral pillar height. And this classification is found to be more reproducible. Then we have stages of Perthes disease. So initially, infarction will occur and will produce a small sclerotic focus. There will be widening of joint space. Slowly, the epiphysis will undergo fragmentation. Then finally, reossification will take place and healing and remodeling will occur. So eventually, in complicated cases, you get to see destruction of the epiphysis, widening of the neck of femur, and coxa plana and coxa magna deformity. Next case. What is the diagnosis? A 25-year-old female over here with left hip pain. No guesses. Okay, left hip fracture is there, but is it pathological or is it just? Yes, it is a pathological fracture. FD, partially correct. Lytic lesion in the neck, right? All right. Some are saying ABC. Okay. So basically, you can see there is a pathological fracture in left femoral neck, which is basically secondary to a lesion over here. The lesion is osteolytic and it is also showing peripheral area of sclerosis over here. This location is quite commonly affected by fibrous dysplasia. And there is another entity also known in this area in the intertrochanteric region, and that is basically it contains fat in it. So you can see on this MR, we can see a focus of fat over here, which is suppressed on the fat suppressed sequence. The diagnosis is liposclerosing myxofibrous tumor. So it is basically a type of fibrous dysplasia only, and it has some amount of lipobeta component in it. So this is LSMFT or liposclerosing myxofibrous tumor. It is a rare benign fibroosseous lesion, which is striking predilection for intertrochanteric region of the femur, and differential diagnosis are interosseous lipoma and fibrous dysplasia. Next case. So this guy is a 19-year-old short-statured male patient with complaint of low backache for 2 months, and there is weakness of bilateral lower limb with inability to walk unassisted for 1 month. What is the diagnosis? Okay. So the spine appearance is quite typical. You can also see involvement of large joints, widening of the epiphysis. This MR also you can see over here. I won't say rheumatoid arthritis because rheumatoid arthritis primarily affects small joints of hand and feet, and bilateral involvement is there. So as you can also see the clinical photograph, you can see there is swelling in the elbows and knees. So this patient, a short-statured patient, so patient is short-statured, means syndromic kind of thing, you know. So the diagnosis is spondyloepiphyseal dysplasia, and in this case, it was TARDA variant. So SED basically is of two types, congenita and TARDA. In congenita, the onset is in neonatal age group. There is severe short-term dwarfism and autosomal dominant inheritance, whereas TARDA has X-linked and autosomal dominant or autosomal recessive trait inheritance. Onset is adolescent, and there is mild short-term dwarfism. And JIE is an important clinical mimic, and but JIE often has an inflammatory component, and it gets response with the help of anti-inflammatory medications, whereas SED will not show a response to anti-inflammatory medications. Other differentials are MPS type 4, multiple epiphyseal dysplasia, pseudoachondroplasia. Next case. So we can see a kind of skeletal survey of a child, neonate. What do you think what it can be? Okay, so we have some answers over here. So you can see, you know, bowing of the long bones over here, and you can also see Wormian bones. So there is bending, and it is because of osteopenia and multiple fractures which have healed. Some have healed, some have, you know, malunited, and they are actually giving a bended appearance in the bones. So this is the case of osteogenesis imperfecta. So it is a So you can see varus deformity of knee, valgus deformity of the hip, bending of long bones, multiple Wormian bones. So this is a case of osteogenesis imperfecta type 3, which presents as a progressive deformity. So basically, there is impairment in the synthesis of calcium in the bones, and it leads to impaired osteogenesis. And as the name indicates, osteogenesis imperfecta, bone becomes weak and it fractures easily. Next case. So what do you see here? You can see a swelling in the retrocalcaneal region. Skin is also tense, and this is ultrasound image, which is showing Achilles tendon inserting over calcaneum. There is a erosion, large erosion in the calcaneum. Okay. So this is basically calcaneal osteomyelitis with retrocalcaneal bursitis. The video again showing the same thing. So you can see a large erosion in the calcaneum and a retrocalcaneal bursal distension with collection. There is swelling in the subcutaneous plane. So this is a case of calcaneal osteomyelitis with retrocalcaneal abscess. Next case. The 19-year-old female with pain in the second metatarsophalangeal joint. What do you see here? Okay. Okay, we have some answers over here. So you can see in this radiograph, there is fragmentation of the head of second metatarsal over here. This is the ultrasound image of the same patient. Contrast lateral side, you can clearly see the head of second metatarsal and the proximal phalanx of the toe forming a joint over here. And here you can see fragmentation of the epiphysis. So this is Freiberg disease. And what is Freiberg disease? It is avascular necrosis or osteochondrosis of metatarsal head. Most commonly affects second, but it can also affect third and fourth metatarsal, bilateral in 10% cases, seen in women, and it is mainly because of high heels. So this is Freiberg disease. Next case. We have a 60-year-old male. Look at the age. 60-year-old male. And you can see a large mass lesion over here in the left, which is almost replacing the left scapula. We can also see focus of calcification. The calcification is classically looking like ring and arc pattern and fluffy pattern of cartilaginous matrix type of calcification. And in this radiograph of the chest, we can see multiple nodules in the lung. So this is basically a case of chondrosarcoma involving the left scapula with pulmonary metastasis. Next case over here. 30-year-old lady with pain and swelling in the right knee. There is involvement of proximal tibia. You can see an osteolytic lesion over here. So this is a case of giant cell tumor or osteoclastoma. So giant cell tumor or osteoclastomas, they are characterized by 4 characteristic radiographic features that I hope majority of you already know. It is closed growth plate, and it mainly occurs in the mature skeleton. Then we have well-defined osteolytic lesion with non-sclerotic margin. It abuts the articular surface and it reaches up to the subarticular region, and the lesion is often eccentric. You won't find any matrix over here. Sometimes there are internal trabeculae And sometimes there are secondary ABC transformation which can lead to multiple multicystic appearance. So that is GCT. What is the diagnosis in this case? You can see multiple calcific foci, which are basically looking like rice grain over here. And this is the radiograph where we can see a cystic lesion with eccentric nodule. So this is a case of myocystic sarcosis. This is another case of myocystic sarcosis where we can see a cystic lesion with eccentric nodule, peripheral vascularity over here. So this is quite common in developing countries, and you may often get such cases. Next case, 7-year-old girl presented with large mass lesion around the knee joint. What do you see? So there is involvement of distal femur. You can see cloud-like calcified matrix. So this is the case of osteosarcoma, right? And on MR, we can see multiple cystic spaces with fluid level. So can you classify this osteosarcoma in a particular category? Telangiectatic, right? So this is the case of telangiectatic osteosarcoma, which is a rare variant of osteosarcoma. It is often seen in 20 years of age. Males are more commonly affected. And in telangiectatic osteosarcoma, the cystic component comprise more than 90%, and distal metaphysis of femur is the most common location. Next case. So this is a case of 45-year-old diabetic male with painless bogey swelling in the right foot. What do you see here? Right. So you must be aware of two types of joint in the midfoot region. First, we have the Lisfranc joint. So in Lisfranc joint is basically formed by the tarsal and metatarsal. So these are tarso-metatarsal joint. And we can see destruction over here. So we have divergent Lisfranc fracture dislocation in the tarso-metatarsal joint. We have bony debris, fragmentation, and disorganization of tarsal bones. All this with the history of diabetes goes in favor of Charcot neuroarthropathy with Lisfranc fracture dislocation. So in cases of abnormal pain sensation and proprioception because of any reason, diabetes is one of them. It can be because of, spine trauma, or when patient does not have any sensation in the lower limb, or it can be because of leprosy also. So any inflammatory response which gets incited from the minor injury, it can result in osteolysis, and it can lead to ongoing inflammation and injury, and it can lead to Charcot joint or neuroarthropathy, which are of two types, atrophic and hypertrophic. In atrophic form, which is the most common form, we have resorption of the ends of affected bone, joint destruction, and there is absence of osteosclerosis in this, and it often occurs in upper limb. Whereas hypertrophic form is it has slow progression, joint destruction with bony fragmentation is common, presence of osteosclerosis is there, and there is absence of osteoporosis. Next case. So what do we see here? So there is history of long-standing soft, non-tender swelling in the prepatellar region, and we have radiograph. We'll look at the density of the lesion. Okay, so the density is quite similar to the subcutaneous fat over here. You can see this is muscle and some amount of suprapatellar, joint fluid may be there, and tendon. whereas this is subcutaneous fat and this lesion is having opacity just similar to the subcutaneous fat. So this is a case of lipoma. This is the radiograph of the same patient where we can see a hyperechoic lesion in the prepatellar region. So this is a large prepatellar lipoma. Next case, patient with multiple joint pain. Okay. So what we can see here, there is calcification of the menisci and there are degenerative changes. Involvement of patellofemoral joint is there. And this is the ultrasound of the same patient, which is showing effusion, synovial thickening, and presence of tiny foci of calcification in the joint. So ultrasound is quite good at picking up floating calcification. So this is a case of crystal-induced arthropathy, which may be because of CPPD. So crystal arthropathies are of two types. It can be gouty or it can be pseudo-gout or CPPD type. So in gouty, first MTP joint is most commonly affected. It has a strong male predilection. Whereas pseudo-gout, it affects knee joint most commonly and men and women are equally affected. And we have two pattern of deposition of the crystals over the articular cartilage. In gout, it gets deposited over the surface, whereas in chondrocalcinosis, it gets deposited in the middle layer. So here you can see two examples. This is gouty arthropathy and this is CPPD. So here we can see a layer of calcification is deposited over the surface, giving double contour sign. And you can, here in this case, you can see calcification within the cartilage. A 25-year-old male with right shoulder pain. What is the radiographic view and what is the diagnosis? What is the radiographic view? Very good. Somebody has answered Stryker's view. Okay. So here we can see this is a Stryker's notch view where we can see the posterolateral aspect of humerus very well over here. There is a defect over the posterolateral aspect of humerus head, and this is Hilscher's lesion. So basically, to look for Hilscher's lesion, we do this Stryker's notch view. And when we compare a simple AP radiograph with a Stryker's notch view, you can clearly see how well this Hilscher's lesion looks like in the Stryker's notch view. And this is how we take this radiograph. So this is Stryker's notch view for Hilscher's lesion. Next is okay, so we have some answers over here. So as you can see, this patient is having a swelling over the surface of the proximal humerus. This is calcified, and this is basically surface lesion. It is showing, calcified matrix over here. So this is a kind of bone tumor, and this is periosteal chondroma, the variety of cartilaginous tumor. So this is the MRI of the same patient where we can see on T2 fat set sequence, the lesion is quite hyperintense, which is a feature of cartilaginous tumor. And in this, you can see some amount of contrast enhancement over here. So this is the case of periosteal chondroma. Next case. Again, skeletal survey of a young patient. What do we see here? All right. So majority of you are right. So here we can see there is osteopenia, prominent trabeculation, and in the metatarsal bone, you can see widening over here, right? And the normal shape, that tubulation is lost. You can see widening of the diploid space. So this is a case of severe anemia with ineffective hematopoiesis, which may be because of thalassemia or any other reason. So it leads to increased hematopoiesis in the medullary space and sometimes in the extramedullary areas as well. So the case of severe anemia with ineffective hematopoiesis. Another case. This is the next case. What do we see here? Okay. So you are right that we can see multiple exhaustosis or osteochondromas over here. Is there anything in the soft tissue you want to comment? Is there in the is there anything in the soft tissues around the knee joint? Yes, it is hereditary multiple exhaustosis or diphyseal eclasis. What is happening in the posterior or the popliteal region? Is it just Baker's cyst, or it can be something serious? There is soft tissue in the popliteal region. So basically, you can see multiple exhaustosis over here in the proximal fibula. Also, you can see there is soft tissue swelling in the popliteal region. And when we did ultrasound for this patient, what we found was there was a large, you know, cystic area which was communicating with the popliteal artery. So this was basically a popliteal artery pseudoaneurysm, and it happened because of constant irritation of the popliteal artery by the osteochondroma. So this is a complication of osteochondroma, which can cause pseudoaneurysm in the popliteal artery. And you can see other radiographs of the same patient and CT. So this is diphyseal eclasis of popliteal artery. So next case. So what is happening here in this chest radiograph? So we have PA and as well as lateral view over here. Is there anything abnormal? Is it because of bone or lung? So you can see in the right upper zone, there is something abnormal over here. There is a mass lesion, which is having almost same density as the bone. And it is having convex angle over here, convex and obtuse angle with the pleura. So this is basically an extrapulmonary lesion. And these are the cross-sectional imaging MRI as well as CT, where we can see the right-sided upper rib, it showed a large osteolytic lesion with expansion and some internal septa were there. The lesion was showing some amount of internal cystic area. So this is a case of giant cell tumor with some amount of aneurysmal bone cyst transformation. Next case. What is happening over here? This is another Potter kind of case. So you can see radiographs of both hands of a patient, and you can see some characteristic appearance of the distal phalanx over here, which look like spade. So these are spade phalanges. And these are other radiographs of the same patient where we can see plantar soft tissue tissue is thickened. There is over pneumatization of the sinuses, and frontal bossing is there, prognathism is there. So this is a case of acromegaly. And in acromegaly, you can find all these radiographic features, and it also affects large joints, and can find early degenerative changes or osteoarthritis in the large joints, can find degenerative changes in the spine. So we should look for the cause, and on MRI brain, it turned out to be because of pituitary macroadenoma. Next case. What is happening over here? So you can see multiple soft tissue nodules over here. You're right. You can also see a soft tissue nodule, which is dense in the prepatellar region, which is another common site for this pathology. So these are basically gouty tophus, and this is a case of gout. So these are the radiograph. These are the ultrasound images where we can see double contour sign, as I have already showed you. And this is the ultrasound image of the tophus. And these are the clinical photographs. Again, same thing. Double contour sign indicates gout. And so this was a case of gout. Another case of different pathology. What is the diagnosis? This is a different patient. Okay. So you can see involvement of the wrist joint, and there is periarticular osteopenia, loss of joint space, involvement of small joints of hand, bilateral symmetrical involvement is there. Bilateral lung parenchyma is showing changes of fibrotic lung disease. So this is a case of rheumatoid arthritis. What is happening over here? This is a slightly tricky case. So you can see multiple bones are involved. Yes, there is collapse, but the density is also abnormal. Also have a look of the ribs over here. The ribs are also not normal. Some of the posterior end of ribs, they are expanded. So basically, this is a case of polyostotic fibrous dysplasia, which is affecting not only the vertebral bodies but also adjacent ribs. So this is a case of polyostotic fibrous dysplasia. Next case. So the patient is a 16-year-old male. So we have an osteolytic lesion in the proximal humeral metaphysis, which is the common location of simple bone cyst. So it is not necessary that simple bone cyst is always unilocular. You may find some internal septa also. And it's a case of pathological fracture. In case of simple bone cyst, they can undergo pathological fracture, and you can find fallen fragment sign and trapdoor appearance. So this is the case of simple bone cyst. What do you see here? right? So we can see erosion of the metatarsals and phalanges over here in the toes. So this is a case of licked candy stick appearance. Is a known case of leprosy, but licked candy stick appearance can also be seen in psoriasis. What is the diagnosis? So you have osteosclerosis all over in the pelvis and long bones, all right? The small bones, bilateral hands and feet also you can see osteosclerosis. But there is a peculiar thing or unique thing over here. We are also having osteolysis in the terminal tufts. That is acroosteolysis. So what does this indicate? This indicates pycnodysostosis. And pycnodysostosis is basically osteosclerosis with acroosteolysis. What is the abnormality over here? No, this is not hyperparathyroidism. Where is the exact pathology located? Yeah, there is a lytic lesion in the sacrum. You're right. I won't say it is involvement of it is because of joint, but there is a lesion. There is an osteolytic lesion in the left sacral ala. Okay. And in sacrum, we often see two, three tumors which are commonly seen over there. First is chordoma, which is central. Giant cell tumor is more commonly seen in the ala of the sacrum. And in this case, it is also showing some amount of cystic changes, which is because of secondary ABC transformation. So this is basically GCT with secondary ABC. And we can also find plasmacytoma. So plasmacytoma is also a good differential. In this case, it was GCT. The CT of the same patient, you can see clear osteolytic lesion with no matrix over here. Next case, we can see pathological fracture over here, tiny foci of calcification. What is happening over here? No, this is not osteomyelitis. So there is a pathology in the femur which is leading to pathological fracture. It is not necessary that pathological fracture always occurs because of any malignant entity. It is mainly, in this case, it is because of intramuscular hemangioma, which sort of involved the femur and it led to weakening of the femur and pathological fracture. So this was a case of intramuscular hemangioma with bone infiltration. Here you can see tiny foci of calcification, expansion of the femur with coarsening of trabeculae. And this is the same appearance that we see in vertebra, that is polka dot sign. And in this MR also, we can see hyper intense, hemangioma in the muscles, and it was quite aggressive that it involved the femur. And this is a rare case, but it can occur in cases of intramuscular hemangioma. It can involve the adjacent bone and can lead to fracture. Next case. So we have two radiographs of the same patient. Right. So we have something abnormal here in the lesser trochanter. So there is avulsion fracture of the lesser trochanter and it is because of metastasis, unless it is proven otherwise, because lesser trochanter is rarely involved by the emergent fracture. So it is pathological. And in the chest radiograph, we can see a large mass. So this is a case of bronchogenic carcinoma with lesser trochanteric metastasis. And these are the CT images. And here also you can see a large mass lesion. There is lesser trochanteric fracture over here. And this is how biopsy was done. And so this was a bronchogenic carcinoma with metastasis. What is happening over here? So we have already seen a case of pycnodysostoses. This is a similar entity. This is osteopetrosis. And we can see sandwich sign over here, diffuse sclerosis of the bone, bone within bone appearance. So this is osteopetrosis. This is a skull radiograph of the same patient. Next case. So what is the pathology over here? So there is involvement of distal end of ribs. There is an expansile lesion with internal septae. And it is a common location of involvement by a giant cell tumor. ABC won't be my first TD because you can see fusion of the epiphysis. And so this is a mature skeleton, and GCT is more common. Also, it is involving reaching up to the subarticular region. Next case, what is happening over here? So you can see there is destruction of the proximal end of humerus involving head as well as neck and proximal shaft. And you can also see ring and arc pattern of calcification, an old age patient. So this is a case of chondrosarcoma of the proximal end of humerus and also presence of metastasis. Another next case, young patient, immature skeleton. What is the site of pathology? You have to also tell me the bone which is involved. Right. So in this case, fibula is involved. You can see onion skin pattern of periosteal reaction. There is involvement of diaphysis. So this is a case of Ewing sarcoma of the fibula. These are the MR images. You can see fibula is affected over here. This also you can see fibula is involved. The case of Ewing sarcoma, there was not much of soft tissue component in this case. Last case. So what is happening over here? Another immature skeleton or pediatric patient. And we can see something is abnormal with the elbow. So basically, you can see humerus is coming over there, and there is dislocation of the elbow joint. The distal humeral epiphysis is completely separated from the humeral shaft. So this is a Salter-Harris type of fracture, which is because of slipping of the epiphysis. So this is type 1 Salter-Harris fracture. So I have shown all the cases, and I think I've finished
Yeah,
on
Sonal, hi,
time.
that was an exhaustive presentation of, I think, all the pathologies that one can come across on radiographs in their exam and also in practice. I'm
Yeah,
sure everyone's going to be
yeah, I
immensely
hope so.
benefited from this. There are